A plastic surgeon specializing in aesthetic surgery. I've been in practice for about 22 years. I started my journey in medicine always knowing that I wanted to be a surgeon from the time I was a little child. No, I really have no idea where it came from. My father tells me from the time I was 6 years old, I said I wanted to be a doctor and a surgeon, and nobody really knows where it came from. I had a great uncle who was an anesthesiologist, but I did not know him. I have no close family members in the medical field whatsoever. I always wanted to help people. So I do remember that. I remember thinking I wanted to, go to Kenya and work in Kenya helping people. We went to Haiti after the earthquake. A lot of the injuries after something like that required plastic surgery. So we had rotating teams of plastic surgeons that were going down to Haiti. We actually were stationed in the Dominican, right across the border from Haiti. And basically it was a makeshift clinic that for the majority of the year was not used. It was used as an ophthalmology clinic where once a year somebody would come and do eye exams. But there were, hundreds of patients there. They knew there was a medical facility there, so they just came across the border and kind of stayed there. And the doctors found them there, and there were orthopedic surgeons and teams from other countries. I particularly remember Spain was there, and there were lots of, volunteer, like missionary type medical groups that were there also. It was really a very rewarding experience working with the patients. They were just very stoic, and they have a lot of religious faith. So they think that, which I do too, that what we go through here, on earth is like temporary, and, the reward is beyond when you pass and you go to heaven. So they have a very good, positive attitude, and it was a pleasure to be able to help them in some way. Oh, it made me realize, how much we have here in the U.S. I mean, we had almost no supplies, but we were still able to take care of patients. We packed up a whole bunch of supplies with us, and we had to take a small plane from the main airport in Santo Domingo, take a small plane to this area where we were going to be working. And I remember the pilot telling me, okay, you're bringing all these supplies. You literally have to weigh the bags and let me know what they are. And if you're not being honest with me, we could crash. So that was interesting. But we brought some things with us, but we still didn't have a lot. And we were able to do, care for the patients in a way that made a positive outcome for them. So when you come back to the U.S. and you see us, opening all these sterile gauze and drapes and, just everything you can imagine, and then even if it's clean and you don't use it, we just like throw it in the garbage. It made me think that, imagine what we could do if like every hospital took the things that were not touched. They were opened, but they weren't touched or contaminated in any way. And we started a collection system, and we could reuse those materials. I mean, how many hospitals are there across the country? I don't even know. But it would be a massive amount of medical equipment that could be repurposed. I went to school in New Jersey, which is where I grew up. And then I did my general surgery residency in New York City at Cornell. And I subsequently did my plastic surgery at NYU in New York City. And then I did a breast fellowship in Atlanta. And then I've been in practice here for 22 years. And I recently started working in Florida also. Yes, I have dual citizenship in a free state and a not free state. Well, it really was what happened during COVID. During COVID in New York State, they basically said, you can't work. We had a 3-month moratorium on so-called elective surgery, which when they first announced it, I thought they meant, plastic surgery, because what we do is all elective as aesthetic surgeons. But no, they meant all surgery, unless you were in a motor vehicle accident or gunshot or whatever. All surgeries were canceled, hip replacements, breast cancer treatment. So that was kind of scary because there are other people who need medical care. So I said, well, if we're going to be in a state where a non-medical person, meaning the governor, is going to decide who can or cannot receive and deliver medical care, I want to have an option where I have a license in another state to work as a physician. And Florida was much more open to that than New York. Well, New York is on Fifth Avenue in Manhattan. So that's on 5th and 94th Street, right across from Central Park. It's a beautiful location. And then the office on Long Island is in a town called Quogue, which is an Indian name, Quogue, and it's out in the area of the Hamptons. So it's open and sunny and usually beautiful, except for February and March. And it's a totally different thing from the city. But everybody, I love it out there. I love it in the city. Both places are great, but it's nice to get out of the city. Even for the patients, they like to go out there and have their surgery because it's just, it's just a lot of sunlight and very cheerful kind of casual vibe out there. So people like it. And a lot of times they'll come out day before or stay a couple days later too, or they have friends that have houses out there. So it's a good place to be. Well, obviously surgical training is like, you're learning your skills. That's key, because if you can't operate and produce a good result, you're not going to be successful. But I think the rest of it just kind of comes from, who you are and how you conduct yourself. So in plastic surgery, interpersonal communication is, I think, very important, because you want the patient to feel heard and you want to really have a clear understanding of what their goals are. So that requires, pretty good communication skills. So I think, you have to be a hard worker. And that's something that you're just born with, or, you find it enjoyable, because medicine is not 9 to 5, even though some people are trying to make it that way. But your patients are trusting you, and you have to be available to them, day and night, 24/7, and you have to be comfortable with that. And I think we've learned a lot over the past, 6 or 7 years, how to better communicate information to the patients so they feel like they have access to information. It shouldn't be like a little closed club where only certain people know certain things. So with breast implant illness, my philosophy has been, since I went into practice, that although we don't have any, hard data at all that breast implant illness exists, my position has always been that everybody's immune system is different, and we don't know if there might not be a small number of patients, or maybe it's a significant number, but I think it's probably small, that their immune system just doesn't really tolerate having a foreign material in it, and in this case, we're talking about breast implants, but who knows? There might be people who have, pacemakers or hip replacements that they're generally older when they have these procedures. So maybe if they don't feel well, it's not so obvious that they're not feeling well. But that's always been my position. And when I first went into practice, I would say most plastic surgeons had sort of the opposite, viewpoint, which was that, we don't have any scientific proof that there is such a thing as breast implant illness. There are no specific studies or labs that can confirm that you do or don't have it. So we're going to go with, it doesn't exist. So that really was the sort of position of most plastic surgeons, was that, the patient is quote unquote crazy. Now, as time has gone on, I've had a patient who was a physician, and she also had a known autoimmune disease that really flared very badly when she was pregnant, and then it subsequently resolved. And years later, she wanted to have very small breast implants. We did saline filled. Well, all the shells obviously have silicone, but the fill was with saline. And her labs were normal in terms of any type of inflammatory markers. And about 2 weeks after surgery, she told me that she was starting to have some of her symptoms that she had had years ago, where she felt kind of foggy. She couldn't think clearly. Her vision was slightly fuzzy. And I said, well, we're taking these implants, out, which we did right away. And her labs were all basically normal, except for her C-reactive protein, which is an inflammatory marker. It was very mildly elevated. If you saw this in any other situation, you wouldn't make anything of it. her symptoms got better and her C-reactive protein became normal. It was 0. So that's a case of a patient who's sort of prone to inflammation, and she definitely reacted to the presence of a foreign body. So I always tell my patients, if you feel like you're not well, we work you up, obviously, to make sure that there is no diagnosable, problem that could be treated, like some type of inflammatory process or lupus, whatever it could be. And then if we want to take them out, we'll take them out. We'll take out the capsule too. And there's probably a 50-50 chance that you're going to feel better. Now, even if they feel better, it could be just that you feel better, like a placebo effect, because you have the implants out and so you think you feel better. But this patient still feels better, so it doesn't really matter why they feel better. And as long as the patient goes in knowing that they may not feel better, which they do, it helps them. I just had a patient 2 weeks ago. I saw her yesterday, and she's like, I feel so much better. So good. And you could tell. You look at her face, you see her attitude. She's smiling more. She's definitely a happier person. So I think she does feel better. And I don't really worry too much about whether or not it's actually physiological or if it's a placebo effect. It doesn't matter. So I'm glad we're having these discussions with patients and we're more open about it. So anytime somebody starts thinking a little bit outside the box in medicine or really in anything else, you sustain a lot of criticism for that. The person that I trained with for breast surgery developed a tram flap, which was used to reconstruct a woman's breast after she had a mastectomy, using her own tissue. And it was a very successful operation and really developed it was the foundation of a whole way of doing breast reconstruction. Now we have free flaps, but it's all using your own tissue, and it all started with Dr. Hartram. And in the beginning, they would have to take part of the rectus muscle, one of the sit-up muscles, to use as the blood supply to the skin. You would basically take the tummy+tuck skin and tissue and keep it attached to the muscle and move it up to the breast, and that you could shape it, and it would be a nice breast. And he would present at the meetings. This was in the 80s. And, the general surgeons would say, this is crazy. You're destroying the abdominal wall. You're going to weaken it. The patient's going to get hernias. I think he did over 800 cases, and he had like 4 hernias, because it depends how you close the area where the muscle used to be, whether or not you're going to get a hernia. If you pay attention to the detail and close it in the proper abdominal layers, you're not going to get a hernia. So, and he was widely criticized and, took the beating, so to speak, and advanced the treatment methods and really helped, thousands and probably hundreds of thousands of patients through all the people that he trained, around the world to help all their women patients. I'm not a person that does, 6 cases a day, because I like to pay a lot of attention to each individual patient, and I don't want to have like a heavy schedule and you're worried about, getting done and what time you're going to finish. I don't like to work that way. So, we'll do 1 or 2 patients a day, a couple days a week, and just nice and steady. And that's what we do. Like I said, I'll do surgery usually 3 days a week, sometimes 4. And then we have, we'll either have 1 dedicated day in New York City for only patients. I definitely do that once a week in New York City. And then on Long Island, sometimes I'll do a full patient day where I'm just seeing follow-ups and new consults, or sometimes I'll just be operating every day, and then we'll see patients for follow-up and new consults at the end of the surgical day. It just depends on, mostly the OR schedule. And then I like to do injections also. And we're going to be introducing some new things into the practice with some cool peels and stuff that we found out about. And lately I've been doing bioidentical hormone replacement, which I think is super important for women and men. And we're growing that side of the practice as well. So it keeps us busy. Well, I love any breast procedure, any breast augmentation, reduction, lift, revision of augmentation, correction of capsular contracture. I just love that. It's very creative. Every patient is different, so every solution is different. It's not cookie cutter at all. I also love doing tummy tucks. They're a little bit more cookie cutter in terms of, the surgery, but you really help women, and they really feel a lot better after they have these done because they just don't feel like themselves. Usually after kids, it could be weight loss too, but they remember what they used to look like and they want to get back to that. So it's very, very rewarding. And breast reductions, I would say, are the most rewarding because it has the most dramatic impact on the patient's life, in terms of their physical feeling, that they don't have pain anymore in their shoulders and neck and back, but also they just have less self-consciousness. They feel more confident in their clothes. They're not, for young people, they're not drawing unnecessary attention. I mean, even for older people, but especially hard for teenage girls, college age girls to draw a lot of attention. They go to the beach, they're wearing an oversized shirt because they don't want to wear a bathing suit. I mean, I can't tell you how many pictures I have of, right around prom. Sometimes they want to get it done too. And, they show me their prom pictures and they're so happy. And it's just really night and day. But it's true of all patients of all ages. It doesn't matter if you're 20, 40, 60, even 70. It is a life-changing operation. So in terms of patient satisfaction, I would say breast reduction is probably number one. But for me, I love doing all of them because they're all creative and you're helping all these people, every single one. Overall, COVID was horrible, but in addition to becoming more educated, it also opened up, options for patients in terms of office visits. It wasn't something that we had really offered before. We would occasionally do it if somebody was like from California or Michigan or something. But they could do a Zoom consult or they could come in person. We usually take about an hour either way. No matter what the procedure is, I like people to really understand, what's involved and sort of the pros and cons. And the longest consultation is most likely a breast augmentation patient because seems so simple, and it is in a way, but there's so much to know about implant choices and what's the pocket going to be under or over the muscle? Where are we going to make the incision? Might you need a revision surgery and why? So there's a lot to go over with patients. And I think we do a very good job of that because I really do spend the time with them on it. And I think other offices, it's like 20 minutes in and, that's it. You can't explain everything in 20 minutes. And that's one of the things that I'm hoping to achieve with our podcast series is to give another way for people to find out the information so they could pop it on in the car or listen to it because it's a lot of information that I give during the consultations and you can't really keep track of all of it, especially if it's the first time you've heard it. So it's nice for the patients to either listen to the podcast about, for example, let's say capsular contracture that can happen with breast implants or, how do we pick the right size and listen to that either before the appointment and or after the appointment. And I think you can absorb more information that way, hearing it just one time. But during any consultation, when people come in, we always encourage them to bring their own pictures of things that they think are pretty, whether it's tummy tuck or breast reduction or breast augmentation surgery. We want to see the aesthetic sense of the patient. So they could get pictures off of my website or they could go on other people's websites as well. And then Instagram. Yep, we post some things on Instagram too. We're going to hopefully expand that a little bit. But yeah, there's things on Instagram. And you can always call the office. I mean, we're always happy to talk to people and give them information. I mean, you don't have to necessarily come in for a full consultation. You can ask some, basic questions to the staff. They'd be happy to answer it. Our team has been in place for a long time, and I'm very grateful for that. They're terrific. The patients love them. They love taking care of patients, and we're all on the same page when it comes to our culture, in the office with regards to how we treat and respect our patients.
To learn more, go to kindofbeautifulpodcast.com or follow Dr. Pfeifer on Instagram at Dr. Tracy Pfeifer, spelled Pfeifer. Links to learn more about Dr. Pfeifer and anything else mentioned on today's show are available in the show notes. The Kind of Beautiful podcast is a production of The Axis, THEAXIS.io.